Good afternoon. Welcome back. I know we gave our residents a drilling. That's good. They need that always. But soon they're going to be giving other residents a drilling, so that's great too. You need to learn how to do that also. Our next speaker is Walter Glannon. He will be speaking about neuroskepticism and why patients are more than their brains. It is a discussion sponsored by the UMA Financial Services. I am particularly happy to have Dr. Glannon here, as I've read his book, and I think it really captures one of the things that's being lost in neurology as we get more and more based in the chemistry explaining what we're supposed to be doing. I think we sometimes forget that the human is a little bit more than the chemistry. Professor Glannon is a professor of philosophy at the University of Calgary. From 2006 to 2010, he was Canada Research Chair in Medical Bioethics and Ethical Theory at the University of Calgary, with a joint appointment in philosophy and medicine. Previously, he was assistant professor of applied ethics at the University of British Columbia and clinical ethicist at the Children's and Women Health Centre of British Columbia in Vancouver. Before that, he was assistant professor of biomedical ethics at McGill University and clinical ethicist at the Jewish General Hospital in Montreal. In 2011, he was awarded a grant from John Templeton Foundation for the project Diminishing and Enhancing Free Will. He has published more than 120 articles and is the author or editor of 8 books, including Bioethics and the Brain, Brain, Body and Mind, Neuroethics and with the Human Face. He received his PhD in philosophy from Yale University. So if you'll join me in welcoming Professor Glannon.
Okay. Thank you, Dr. Varma, for that nice introduction. I am very grateful to the Society and to Teresa for inviting me. It's a real honor for me to be speaking with you today. This is the first time I've ever given a talk to people who are having lunch or dinner. I hope I don't cause any indigestion. Dr. Varma in the introduction said that I had worked as a clinical ethicist. I have to tell you a story about that. I grew up in New England, and I've lived in Canada for about almost 20 years now. So, as you know, in the United States, anyone who works in anesthesia is called an anesthesiologist. In Canada, and it's probably following the British tradition, they're called anesthetist. So when I was working as a clinical ethicist about 10 years ago, I had some problems with cardiac arrhythmia. So I went to a cardiologist, and he said, well, morphologically, there's nothing wrong with your heart, but I'll send you to this electrophysiology group at a different hospital. And he said, by the way, what do you do? And I said, well, I'm the clinical ethicist at the Children's Hospital in Vancouver. And he said, oh, okay. So he wrote it down. So a few months later, I saw one of the cardiologists in the electrophysiology group. And the first thing he said to me was, I see you're working in anesthesia at Children's Hospital. And I thought, what? And then I realized that the first cardiologist thought that I had said anesthetist rather than ethicist. And then he made a joke about how ethicists just put people to sleep anyway with their opinions. So. Anyway, more serious matters. There's been remarkable progress in clinical neuroscience, especially in the area of neuroimaging, brain imaging, especially in the last 20 years, but you can even go as far back to the early 70s with the advent and use of CT scans, head CTs. EEGs had been available and could detect abnormal electrical activity in patients with seizure disorders, but the ability of imaging to display anatomical features of the brain was really quite an achievement. And that developed further with higher resolution MRI, structural imaging. And then another advance, further advance, was in the 80s with PET scans, and even more so with functional MRI in the 90s, which could display and measure and monitor brain function or dysfunction, and in some cases of dysfunction, show correlations between the dysfunction and some patients with some neurological and psychiatric disorders. This was significant because it did something, shed light on something that had been elusive, namely the neurobiological and the neurophysiological underpinning of much of our thought and behavior. And more recently, imaging and other techniques, other interventions, for example, examining cerebral spinal fluid, have identified certain biomarkers that may predict that certain individuals may develop a psychiatric or a neurodegenerative disease later in life. So these are all, as I said, really remarkable advances in neuroscience. And outside of the clinical neuroscientific context, there have been a number of studies trying to identify the neural correlates of moral reasoning and decision making. In particular, there have been a number of studies examining the brains of psychopaths, individuals with psychopathy, especially those who are criminal offenders, and have shown that there are correlations between dysregulation in frontal, limbic, specifically amygdala pathways, and that there are correlations between the brain features and the behavior. Now, this has led a number of people in neuroscience to make the claim, what I would say an immodest claim, that neuroscience can or will provide a complete explanation of human thought and behavior. If you want to know what an individual is thinking or why they acted as they did, look in their brain. And this is, I think, misleading, exaggerated, and in some cases dangerous, because it fails to appreciate the fact that factors both inside and outside the brain are necessary for us to get a better understanding of our thought and behavior. And against those who make the claim that neuroscience can provide a complete explanation, I and many others would say that what we should do is make, at most, the more modest claim that neuroscience, in the form of imaging, but in other respects as well, will, at best, provide a satisfactory, at least for the time being, explanation of behavior, and maybe even more modestly, an approximation to an account of human behavior. So there are reasons for skepticism about these neuroscientific claims, hence the title of the talk, Neuroskepticism. Okay, so these are the objectives. I mean, the main issue here is the claim that many make that you are your brain, that everything about you can be explained in terms of examining various features of the brain. Okay, so some people call this neuroreductionism. Neuroessentialism is another term that people use. They're basically the same. I mean, basically, it says that the mind, that our desires, beliefs, intentions, all of our psychological properties can be explained entirely in terms of anatomical and structural and functional features of the brain. In philosophy, we call that reductive materialism. That is, all mental states can be fully accounted for in material terms. So just in terms of neurons, synapses, synaptic connections, all the different components of the brain. And that's going to give you an account of our behavior. This position really goes back to Hippocrates. And interesting, this is when he was writing about epilepsy. He said, men ought to know that from the brain, and the brain only, arise our pleasures and joys, laughter and jest, as well as our sorrows, pains, grief, and tears. It is the brain which makes us mad or delirious, etc. Okay. And then echoing the same theme, a book which many of you are probably familiar with. This is Francis Crick's The Astonishing Hypothesis. And right at the outset, I think the first paragraph of the book, he says, you are, in fact, no more than the behavior of a vast assembly of nerve cells and their associated molecules. More recently, Schwab is a neuroscientist. Said we are our brains, a neurobiography of the brain from the womb to Alzheimer's. And then Sebastian Seung, the idea of a connectome, which is quite popular in cognitive neuroscience circles, that how the brain's wiring makes us who we are. So if you want to understand, or the best answers to the question of who we are, what makes us who we are, the mental states, the psychological properties, basically what you should do is adopt a reductive account, a reductive materialist account. Look into all the synaptic connections. That's the way you're going to get a better understanding. That's the way you're going to answer that question. So there are two views of the brain here. The one I've just presented, Hippocrates, Crick, and others. And I'm a bit, this may be I'm generalizing here, but I find that many people in what's called cognitive science or cognitive neuroscience, who usually work with animal models and do not work with patients, tend to, I'm not going to say they always do, tend to make these claims, as distinct from people who work in the clinical neurosciences of psychiatry, neurology, neurosurgery. That's a generalization, okay? So, but that's what I've experienced. So view one, which is the Hippocratic and Crickian view, is that we're nothing more than our brains, our conscious and unconscious thoughts and behavior at sensory motor, cognitive, affective, volitional levels can be explained entirely in terms of neuronal processes. And what they usually do is do imaging studies to confirm this. So this is the is of identity. If you haven't had philosophy, there are two senses of the word is when you're talking about identity. This is that everything about us, if you want to, the is of identity says that something completely defines who we are. There's nothing left over. Okay, the second view says that we are our brains, but we're more than our brains. There's much more involved here. We're our brains plus internal systems, the immune, endocrine, cardiovascular, and external properties, the proprioception, somatosensory feedback we get from the body, and the influence of the natural, social, cultural environment on our mental states and how they shape, influence the structure and function of the body and brain. So they also say, people who hold this view, that the conscious and unconscious states, or the mind, is not located in the brain, but it's a process or an activity that emerges from interaction among all these factors. Okay. So this is what philosophers would call the is of constitution. That is, we're constituted by our brains, but we're constituted or made up by other things as well. So the brain is a necessary component of what we are, but not sufficient. You have to appeal to other things to explain who we are. So the first model is reductionist, it's inward, it's narrow. Again, I'm generalizing here. Explains thought and behavior by analyzing local and distributed synaptic connections, neural circuits, networks, etc. The non-reductionist is more outward, it's broad, explains thought and behavior, not only in terms of, so it's not dismissing or rejecting neural models, but not just in terms of these models, but also in terms of how these processes are influenced by bodily systems, internal and external, as well as different aspects of the environment. So it takes the brain to be one feature of a subject or an organism or a person who is interacting with other people in the natural, cultural, social environment. The non-reductionist view, which is, Stephen Rose is a biologist in the UK, and there are many others. In the 20th century brain, he defends this view that he says brains are not conscious, people are. And I bring this up because I said that generally speaking, people in cognitive science tend to hold that reductionist, narrow first view of the brain. And I recently read a book by a neuroscientist who was talking about consciousness as something that the brain does or the brain achieves, rather than people with brains. So our brains enable our consciousness in providing us with some control of the environment in which we are embedded. So it's what philosophers would call non-reductive materialism. It's not dualism. I'll say a little more about that later. So the mind is necessarily generated. Our beliefs, our desires, our intentions, our emotions are necessarily generated and sustained by the brain, but they're not reducible to. So there's certain aspects of it. In one of the slides, I talk about the phenomenology of experience. That is, what that means is what it's like subjectively for a person. It could be, for example, for a person who is experiencing the early stages of dementia, there's a psychological, experiential component aspect to that, which can't be captured by just looking at brain morphology or pathology in the brain. Okay. So I mentioned Stephen Rose, and Adam Zeman is a behavioral neurologist who is a proponent of this idea that when we're trying to explain consciousness, you don't just look in the brain, but you look at the person or the subject as an organism who's interacting with the environment and trying to adapt to it. Thomas Fuchs is a psychiatrist from Germany, and he has a book. He's written a book called The Brain, a Relational Organ. He said, the brain is not the sole producer of the mind, but a relational organ that mediates interaction between the subject and the world. Okay, so a lot of this second view is part of an evolutionary or sort of an adaptive model of individuals interacting in the environment. So it doesn't isolate the person and the person's brain from everything around them. Cortical processes in the brain are constrained by subcortical processes in promoting homeostasis of the organism and the environment. Okay. The citation I had there is Todd Feinberg. He's a neuropsychiatrist. This is a little, it's a further expression of this view. Elvinoui is a philosopher, and this is controversial, but I mean, this is taking this second view farther. Some people would say to an extreme. Not everyone agrees with him, but he said that consciousness is not just a higher level process emerging from lower level processes in the brain, but an activity that the subject engages in when interacting with the external world. Now, this is similar to what the behavioral neurologist Adam Zeman I just mentioned is saying. Okay, so it's this expansive view of consciousness in the mind, and the brain is something that enables the individual to adapt, interact with their environment. Another critique of the reductive materialist, neuroessentialist, neuroreductive view is by two philosophers, Bennett and Hacker, who published this book in 2003, and they were among the first to identify some of the conceptual problems that some of the neuroscientists were making in making these claims about neuroscience being able to provide a complete account of everything we think and do. And what they pointed to was this, what's the mereological fallacy. It's the parts and wholes fallacy. It goes back to Greek philosophy. That is, neuroscientists make the mistake, not all, okay, of attributing properties of a whole to only part or parts of the whole. Okay, so they're attributing properties to an organ, the brain, which that you can only attribute to the person or the entire organism. So again, it's the same idea. So I mentioned Hippocrates and Crick. There are neurologists who could be described, or what they do could be described roughly as evolutionary neurology. John Hewlings-Jackson, well-known neurologist in the 19th century, studied sensory motor processes, and he was concerned with how they became embedded in networks of connections that relate them to adaptive functions. But what's interesting here is what he says about mentation. It's what arises with mentation is the organization of many different nervous arrangements, okay, in our highest centers during actual converse with the environment. Okay, so the environment is important here for brain structure and function development. And even more so, the famous Russian neuropsychologist Alexander Luria, who's done these fascinating studies of the Russian soldier Zizetsky, the man with a shattered mind, about studying what his life was like with his brain injury. Also, the author of the book *The Mind of a Mnemonist*, I can't even say it. About this individual, Shereshevsky, who had incredible capacity for memory retrieval, but he was disabled in many other respects. So for Luria, the brain is part of a functional system that projects into the cultural, historical world. So again, another example of this expansive view. These are neurologists, neuropsychologists, not philosophers, but they appreciate the importance of contextualizing the brain and the conscious and unconscious mind that emerges from the brain within a wider framework. So some psychiatric conditions that I think are best explained by adopting this second model, this expansive non-reductive model, are, at least in some respects, major depression, generalized anxiety, obsessive compulsive disorder, the negative form of schizophrenia. I don't have time to go through all of these, but I'll say a few things about at least depression. This is a diagram. The bottom of it I couldn't get in here. There's a caption and a description. Can't really. And so it's a disease of the mind, brain, and body. And what it says in the caption is that in cases of depression traceable to severe stress, what happens is that there's dysregulation of the of different axes in the body. There's secretion of high circulating levels of cortisol and noradrenaline, which exacerbate, heighten the fear response to stimuli. Cytokines such as interleukin-1 and 6 and tumor necrosis factor can be psychoactive. My wife has had depression for a number of years, and it's under control. But what's interesting is that whenever she gets a flu, there's a return of some of her symptoms. And her psychiatrist and she and I believe that the virus triggers the release of cytokines. And that, it's, we're not sure, but certainly a plausible explanation for it. So a number of systems in the body can contribute to depression. And in turn, the dysregulation in the brain resulting from depression can affect adipose tissue and a number of metabolic systems in the body. Okay. So, so the HPA axis is dysregulated. And what it says in the caption is that depression with the release in particular of excess cortisol and noradrenaline, creates an adverse biochemical environment in the body and the brain. So it's not just the brain, it's the body as well. Sorry for this. This is really crude, but I couldn't find a diagram that really captured what I wanted to say. If I were applying for a job as a graphic artist, I'd be in big trouble. But so anyway, the idea here is that, wait a minute. So the central nervous system is affected, as that earlier diagram showed, it can be affected by the cardiovascular system, the immune, the endocrine. So if we're talking about the mind, it's really embodied, okay, in that sense. And the mind is an emergent property, but the mind can also, in turn, affect the brain. If you have extreme stress triggered by certain stimuli in the social and natural environment. So in that sense, individuals are not just embodied, but they're also embedded in an environment. So I think it only tells part of the story if you focus on the central nervous system. But really, what you need is more of a holistic model to get a better sense. And even so, as I said at the outset, I think we should be modest and not say that even this sort of holistic model is not going to completely explain everything about the brain and the mind, brain-mind relation, but give us a better understanding of it. Okay. Epigenetics is another issue which requires us to go outside the brain. This is a recent article by Eric Nestler, a psychiatrist, that environmental exposures interact with an individual's genetic constitution, determining risk for depression throughout life. So in certain vulnerable individuals, this could be due to genetics. Severe stress can trigger adverse changes in genetic loci in brain's limbic regions. There are stochastic events that occur during development, and there's also the idea of inheritance across generations. So all of these are factors that have to be considered when you're talking about depression as a psychiatric or a disease of the brain. It's really more than that. On the one hand, biological psychiatry has done a lot, I think, to reduce the stigma associated with mental illness. That is, in the past, it was more common for people to say to someone who had depression or anxiety disorder, well, it's all in your head. Well, there's a lot going on in the head, and genetics and neuroscience has, I think, done a lot to show that many of these disorders are, at least in part, brain disorders, and that individuals are not responsible for them. So I think it's helped to reduce the stigma. And the research domain criteria, there's a lot of debate about whether this should be adopted instead of the DSM. And Thomas Insel and other psychiatrists, Steve Hyman, have been arguing for adopting this, basing psychiatric disorders, the diagnosis and treatment on genetics and identifiable neural circuits rather than just symptoms. I think these two really should be thought of as complementary, not exclusive of each other. Eric Kandel wrote a landmark, very important paper published in 1998 about biological psychiatry. But in talking about identifying the neural circuits and the genetic factors, he also emphasized that the social factors were involved. They could influence the structure and functional properties of the brain. But then, I mentioned Insel in the previous slide. He says that mental disorders are disorders of brain circuits likely caused by developmental processes shaped by complex interplay of genetics and experience. So this idea of circuit disorders, which has been strengthened to some extent by work in functional neurosurgery, deep brain stimulation, for example, for depression. I'm going to say something about that in a minute. So the question is whether the advances in neuroscience, identifying neurobiological, neurophysiological, and genetic, combined with genetic factors, is really a burden or a blessing. And it does seem to have, it's helped to explain to some extent that when someone has a mental disorder, it's not something that they're just making up or imagining. There is something going on inside of them. There is dysregulation, but it can also go to the other extreme, and this is something that Fuchs, the psychiatrist I mentioned, is worried about. He says that a reductionist biological concept of mental life may lead to self-alienation. In the wake of popularized neurobiology, we are beginning to regard ourselves not as persons, having wishes, motives, reasons, but as agents of our genes, hormones, and neurons. Stigma, and this is John Sadler, another psychiatrist, says that stigma requires much more social, moral, educational, and political attention than neurobiological attention. Now, neither of these psychiatrists would say that the neurobiological and neurophysiological are not important. Indeed, they are. They're necessary, but we have to, our focus has to be broader in diagnosing and treating mental disorders. Okay, so I at the beginning I was talking about all these advances in neuroscience and primarily in the area of neuroimaging, structural and functional neuroimaging. So most of the neuroreductionist claims, that you are your brain, are based to a large extent on structural and functional imaging. Except in advanced stages of disease, imaging may not detect neural abnormalities and psychiatric disorders, can't always explain behavior. Okay, Andrea Yates, many of you are probably familiar with this case, the mother who killed her children, and they did an MRI, and one of the lawyers in the case was questioning the use of imaging to determine her guilt or innocence, and he said, you can't tell why from an MRI. That is, you can locate, you can identify certain neurocorrelates maybe of behavior where an individual seems to not have control over their thoughts and actions. But those correlations are not going to tell you exactly why they did it. So PET and fMRI, measuring levels of blood oxygenation and glucose metabolism, there are indirect measures of brain activity, and they provide correlations between neural networks and thought and behavior, but it's very important to keep in mind that correlation is not causation. And unless and until, and I don't think it's ever going to get there, neuroscientists can show that a correlation between certain dysregulation, dysfunction in the brain, and some kind of abnormal behavior, that one causes the other, we should keep a healthy dose of skepticism about these claims that neuroscience is going to be able to explain behavior. Okay, so another claim that neuroreductionists make is that this is called epiphenomenalism in philosophy. That is, mental states are caused by physical states in the brain, but mental states themselves don't have any causal efficacy. So mental states, they exist. I have thoughts, desires, intentions, beliefs, but they don't have any causal efficacy on what happens to my body or brain. Cognitive behavioral therapy, I think, challenges that assumption. In a number of studies, this one is just one that I'm mentioning from 2004, cognitive behavioral therapy did cause changes in cortical regions of the brain in patients with depression. So the mind, certain mental states can, in a top-down manner, alter brain function. Okay? And that goes against reductive materialism. Okay. What's really significant here, and this is one of these social, cultural factors I mentioned, is the patient-therapist interaction. Someone, you all know about the white coat syndrome. And so there's a wide range, it's very multi-dimensional picture of patient-provider, patient-doctor interaction, all the psychological aspects, expectations, condition responses, all of these in a wide range of therapies can affect outcomes. So there's a lot going on here. So brain function and the mental states that arise from it are not just, or can't be explained just by appealing to the brain, but by this broader context. Okay. I should have put a different slide in here, but anyway. So there are neurological conditions which the full impact, force of which I think have to be explained outside of the brain by appeal to certain factors outside of the brain. I can't do all of these, but I'll do, I think, the first 4. I started at 10 after, right? Okay. All right. So this is hydrocephalus. Okay, that's just the image. Okay, now this is interesting because I mentioned Todd Feinberg, this is a neuropsychiatrist, and in his book, Altered Egos, he mentions this patient who came to see him. She was complaining of paranoia, thought she should see someone. She was a college graduate, she was an executive secretary. The neurological exam was normal, but Feinberg noticed that she had an unusually large head. A CT scan revealed that over 3/4 of her cerebral cortex was missing. So most of her brain was composed of cerebral spinal fluid. She had severe structural abnormalities, appearing in imaging, not necessarily indicated of pathological behavior. So the idea, the takeaway Feinberg says, is even though she had hydrocephalus, actions speak louder than images. And I mention this actions speak louder than images because imaging is playing an increasing role in the criminal law. I mentioned Andrea Yates. Structural and functional imaging are being increasingly introduced in courts of law usually to argue for the defense that an individual lacked control of their behavior. And they will appeal to an abnormal brain structure or function to argue for that. But for example, just one example, structural MRI or CT, there could be a lesion in the person's brain that was there for years, and the brain and they could have adjusted to it. It's possible that it doesn't affect their behavior at all. So there are these problems with imaging when you're trying to do post hoc diagnosis of an individual's behavior at a certain time, and a number of other issues. But this is something where the legal community and the neuroscientific community are going to have to work together to monitor it. So deep brain stimulation is a form of neuromodulation. It's a standard of care in many places for Parkinson's, for movement disorders, considered experimental or investigational for psychiatric disorders. It's used both as a probe and a modulator. And I say probe, this is interesting because this idea, my claim that we are not our brains, we're constituted by but not identical to them, was challenged by someone. I co-authored a paper with a neurosurgeon. He's a resident. It was about the effects of deep brain stimulation on identity. And I published a paper called Our Brains Are Not Us. And he said, I read your paper. He said, I don't agree with you. He said, we really are our brains. And I do these with Dr. Lozano, that's his mentor, these deep brain stimulation studies, and not only modulating, but we're actually probing different circuits of the brain. And I can tell you that you can explain everything about human behavior, or just about, by probing in their brain. Okay. But that doesn't explain, as I was saying earlier, the subjectivity of someone, for example, who has Parkinson's, who was not able to control their, who had motor control problems, and then suddenly or almost suddenly, they're able to control it. There's an adjustment, a psychological adjustment there for them and their caregivers, which you cannot explain by just appealing to structural or functional features in their brain. Okay, this is just a diagram of what happens. You've got the pulse generator, usually implanted under the collarbone. Stimulation occurs bilaterally or unilaterally, usually in the subthalamic nucleus or globus pallidus interna. But to really understand the effects of neuromodulation, we have to go into investigate psychological and social impact on patients and families. There's a big adjustment for a lot of families when they've been caring for someone who can't take care of themselves, and all of a sudden there's this tremendous transformation. In many respects salutary, I mean the therapy has been effective, but there are other issues that have to be dealt with. I'm not saying that we shouldn't do it, just that these are issues that require more than just a neurobiological explanation. Okay, I mentioned the willow tree. The willow tree is an Iranian film. I saw it about 6 years ago. And it's not about deep brain stimulation, but the take-home message is similar. There was a university teacher who was blind. He could see at birth, but he developed blindness. I'm not sure what the disease was. And he heard that there was a surgeon in Paris who could cure him of his sight, restore his sight. So he went there and his vision was restored. Had this great homecoming, everyone was really happy. But psychologically he changed. It's not clear, it wasn't clear from the film whether there were neurological or psychiatric sequelae from this procedure, I don't know. I mean, the implication was, or the assumption was that there wasn't, that he just had difficulty psychologically adjusting to the change. He started pursuing other women, was abusive to his wife, neglectful of his daughter. They abandoned him. And then at the end, he ends up burning his apartment. It's an extreme case, but it's something that makes you think about the importance of these social and psychological factors. Okay, brain-computer interfaces. This is really something experimental. But it has been effective for some patients with tetraplegia. They can move a computer cursor or a robotic arm by implants epidurally, subdurally, sometimes right in the motor cortex, so they can translate their intention to act into the action by moving the cursor of the robotic arm. But what many people who discuss this fail to or don't adequately consider is that there's interaction between, there's a practitioner who's training the patient to do it. So here again, here's an example of something outside the brain, outside the patient. This interaction is really crucial. So there's more than one agent in the process. There's a shared control of neural processes between the patient and the practitioner. Neurofeedback is another example. Patients in chronic pain, it's been used in depression, they can see images of their brain on EEG or fMRI and modulate their response to the pain or the mood disorder. But again, it depends on how effectively they are trained and respond to the practitioner. Okay. Fabrizio Benedetti is an Italian neuroscientist. He's written a lot of really important, fascinating work on the doctor-patient relationship and how it plays into placebo responses. And he makes an important point. This is in his book, The Patient's Brain. He said, the therapist has a central role in triggering all those mechanisms that take place in the patient's brain, from seeking and hopeful behavior to expectation and placebo responses. So it all occurs. Brain function, dysfunction, and the whole brain-mind relationship really has to be contextualized in this in a biopsychosocial model. Okay, this is the same idea. I mean, there are interesting studies of Parkinson's patients who were able to generate endogenous dopamine even though they were not given a dopamine agonist. So the expectation that they had was able to trigger this. I'm not sure how much time I've got. Okay, psychogenic movement disorder is very interesting. So usually triggered by some severe stress, not organic, at least the etiology is not, it's psychological. Disability scores are similar to those of patients with organic movement disorders such as Parkinson's. Treatment options, cognitive behavioral therapy has been done. Some neurologists advocate placebo therapy. There was a recent, I think about a year ago, in Nature Neuroscience about using placebo therapy for PMDs. And it has been shown to modulate reward pathways in the striatum. So it's conscious expectation combined with unconscious conditioning in a lot of these conditions. So neuroimaging and neuroskepticism. Skepticism about neuroreductionism is warranted because many of the claims that neuroscientists, and again I will say mostly people in cognitive neuroscience, not clinical, are based on neuroimaging. Structural imaging showing abnormalities is not necessarily indicative of pathological behavior. Functional imaging is not a snapshot of what occurs in the brain, but is a construct based on statistical analyses averaged over many scans and many imaging trials. So there's an inferential distance between imaging and behavior, making claims or statements about an individual's behavior. Again, as I said earlier, correlation is not causation. This says a lot about me. Okay, in doing this, I showed this to a neurosurgeon, and he said, well, okay, what are you saying, that the brain is just a black box? No. Okay. We can't find anything that is, there's a lot in there, but we're not finding anything that's going to tell us about the subjective quality of your mental states, why you have the mental states you have, how it is that the brain gives rise to the psychological properties we have. So it's just one way of being cautious about claims about the brain-mind relation. So what are we? We are our brains, but we're not just our brains. We're also embodied subjects interacting with other subjects in the natural and social environments in which we are embedded. The mind emerges from this interaction. The etiology and symptomatology of many neuropsychiatric disorders are a function of biological, psychological, and sociocultural processes, internal and external to the brain. So what's both inside and outside the head is important here. We need an ecological view. This is a term that some people in neuroscience use, of the brain as more than an isolated, self-contained organ to understand these processes and understand why people behave, or at least to approximate an understanding of why they behave as they do. This is from a book by Sally Satel. I don't always agree with her views, but I agree with just about everything she says in this book, Brainwashed, which was published last year. And basically, she's criticizing all the hype about neuroscience and all of the claims about brain science explaining everything about us. She said, they say, although scientists can describe human behavior on a number of different levels, the neuronal, the mental, the behavioral, the social, they are not close to bridging the yawning gap between the physical and psychological. The brain enables the mind and thus the person, but neuroscience cannot yet, if ever, fully explain how this happens. This is from Raymond Tallis, another neuroskeptic, a clinical neuroscientist. He did a lot of imaging studies, but has been very, very skeptical about these extreme claims. And this is a nice way to end. He said, when scientists are tempted like Crick, remember Crick at one of the first slides, echoing Hippocrates to assert that you are no more than a vast assembly of nerve cells and their associated molecules, they should recall that brains are meaningless without bodies, that bodies cannot function without environments, and environed human bodies are not human bodies without societies. Thank you. So do I entertain questions or? Oh.
So where would you put the person's will as self-direction in all of this?
Wow. There are cases where the will as self-direction can be impaired by certain neurological or psychiatric disorders. For example, if someone has severe, moderately severe depression, or the negative symptoms of schizophrenia where they have avolitional syndrome, or so they have anhedonia and avolition, they really can't bring themselves, they can no longer experience, have pleasurable experiences that they used to have, or they can no longer bring themselves to form an intention and execute it in an action. Those would be cases where appeal to neurobiology could be very helpful, but I think those are just in severe cases. And I mentioned Luria's patient, Zazetsky, who had a brain injury and had significant impairment, but he was still somehow able to retain and exercise his will to a limited degree, but he was still able to do it. So my response would fit in with that broader model too, that neurobiology, neurophysiology would be necessary to answer that question, but there are a lot of other factors. Social environment, what stimuli there are, what sort of interactions the individual is having, what sort of incentives there may be. Social cues can play a role here as well. But the neuroscience I think, would be important and indeed even necessary to determine whether the individual had the capacity to do that. It wouldn't be that, it wouldn't provide a complete explanation of that, but it would be an important part.
Question. These near-death experiences where people always see a light in the out in the horizon, I mean, that's always the same story. So my question is it truly a spiritual thing, or is it just the brain shutting down or dying? And that's one question. The other question is all our demented patients usually go through the same series of changes in their personality. Paranoia is a big one. And I'm just thinking, again, is this something that has been studied, or do they ever bring people to death and bring them back and find out? I mean, these are weird questions,
No. There have been studies done of some neurologist, Olaf Blanca in Switzerland, has done experiments, and he claims that he can trigger out-of-body experiences. And he claims that the out-of-body experience can be explained by certain activity in the temporal parietal junction. I mean, I think there's more to it than that. It could be, even if that's part of an explanation, it's quite possible that a person's spiritual experience over the course of their life could influence that. I don't know, or because even though people report these experiences, my sense is that they're probably qualitatively or subjectively different in some respect. So I don't think you can give a reductive account. I mean, it's not to deny that there is certain activity going on in that region of the brain, but I think there's more to it than that. Okay, was the second question about dementia?
Well, everybody goes through the same stages, it seems like.
Yeah.
They're all paranoid, and then they all go through this calming stage and a violent stage.
Yeah.
And again, these are all just changes in the...
Yeah, even with that, the course is not always the same. My mother has dementia. It was diagnosed as Alzheimer's, I'm not even sure. She didn't have the personality changes. It was semantic difficulties retrieving words initially, and then serious motor problems. But her personality really didn't change the way it does with other people. So I suppose a neuroscientist could say, well, the changes in her brain, the atrophy, the degeneration is in different regions, and that would explain it. But so that, I think, would be part of an explanation, but not the whole explanation.
With a change from neuroreductionism to material reductionism, have you not shifted the argument from one organism to several organisms? And if several organisms are still organized by chemistry and non-free will, is it simply just sidestepping the argument for another time?
Okay, so the many different things, would they be what? Well, what would those elements?
So the argument against neuroreductionism, as I am hearing it, is that there's an ecological context to the brain-mind.
Right.
But if there are 100 different atoms interacting, one atom is unfair, but 100 different atoms still explain the behavior, if we understand the mathematics behind it.
Yeah, so there will be, so not, the explanation of behavior will vary from person to person. So you could, so using your example, so if you're talking about atoms, maybe one atom would play a greater role, or one component of this whole framework would play a greater role than another component. In the case of one individual, maybe it would not play such a great role, and some other component would play a greater role. Now, some people would say that is still a reductionist view because you're still explaining everything in terms of all these atoms or components. My sense is usually when people attempt a reductionist explanation, they're trying to get to the core of something and to identify a unique, localizable element, factor, that's going to be the crux or the core of the explanation. And usually when people advocate the holistic view, they don't think of it as a reductionist explanation. Well, even if all of these elements figure in an explanation, the subjectivity or the phenomenology of an individual's mental states, I mean, there's something elusive about that. So if someone is in the early stage of dementia, they know that, they're aware of the fact that they have dementia and it's going to progress. They don't want to have it, but they have it and they have to accept it. There's the psychology of that, to me, is not the sort of thing that can be explained over the whole population of patients who have dementia. So these are, I mean, some neuroscientists and philosophers would say that what I'm doing is advocating sort of this mysterious view that there are things that we just can't explain. But I do think that there are aspects of subjectivity that do elude explanation, that only the individuals who's having that experience can describe, can tell you what it's like.
Question over here.
Yes? Okay.
Since the neurotransmitters act on distances that are governed by quantum effects, such as uncertainty, I'm wondering if quantum theory provides any information on mental processes.
Yeah, okay. You know, it's interesting because in the whole free will debate, some neuroscientists and some philosophers have said that quantum processes in the brain actually uphold the notion of free will. That is, what really challenges free will is the idea, or threatens the idea, our conviction that we have free will is determinism. So that processes in the brain like events from the past and natural laws determine that what we do at a certain time is the only thing we could have done at that time. So you can move inside the brain and say that neural processes uniquely determine the certain mental states and the actions we perform. So there are some people who say, well, no, it's not deterministic, it's actually governed by quantum processes. And that gives us an out from the concern, the worry about determinism. But there's a problem with quantum processes, and that is whether that's enough to ensure that we have control of our mental states and actions. So the idea of quantum indeterminacy for some people, and I don't really know what to conclude about this. Quantum indeterminacy for some people suggests a different type of lack of control that determinism does. So we wouldn't have the sort of control we really need to have free will. So it's particularly relevant to the free will debate. And there's been a lot written on neurosciences, the implications of neuroscience for free will. Ever since Benjamin Libet, he did some experiments in the 80s, and a lot of philosophers and neuroscientists have been going back and forth on that. So, but the quantum indeterminacy is a big part of that. Yeah. And there's no agreement about whether it undermines control or actually ensures that we have control of our behavior.
Yeah. As physicians, we're pretty practical people generally. And as an ethicist, you're probably less concerned on a daily basis with do we have free will, or more so with how do we use it and how responsible we are. I wonder if you would elaborate on the implications of ethics with regard to neuroreductionism and the doctor-patient relationship.
Okay. There's a field called neuroethics that has developed, and a lot's been written about it in the last, since 2002, I suppose. Some of it has to do with the neuroscience of ethics. That is, when I was earlier, I was talking about how studies are being done to identify the neural correlates of psychopathy, moral reasoning, or the inability to engage in moral reasoning. But there's another sense in which ethics and neuroscience has been going on for years. So, for example, a neurosurgeon resecting a tumor, or clipping an aneurysm, or trying to deal with an arteriovenous malformation. So there are risks involved, and ethical issues there have always been how the physician presents the information to the patient. Does he or she present it in a way that's informative enough, clear enough, so that the patient, assuming they have the capacity to process the information and make a decision that's in their best interest, that they have an obligation to present that information in that way. That's really part of respecting the idea of informed consent and patient autonomy. But together with that, this goes along with the rest, is this principle of non-maleficence, that physicians have an obligation not to harm their patients. So in neuroscience, as in any area of medicine, these principles of ethics, of bioethics, autonomy, respect for patient autonomy, and which is patient-centered, but physician-centered idea of non-maleficence and beneficence, doing what will benefit patients and not harming them. Now, in neuroscience, what's particularly significant ethically is, I was talking about deep brain stimulation for motor disorders, which has become, as I said, it's standard of care in many centers. But it is still experimental for psychiatric disorders. And there the issue is whether certain patients may be exposed to unreasonable degrees of risk. Also, whether patients whose condition has been refractory to pharmacology, for example, may be desperate for any sort of therapy, will ask to be included in a clinical trial. There may be the therapeutic misconception involved here that they may think just by participating in the trial that they will benefit. So there are all of these issues that have to be considered by the physician. So it's relying on principle, but it is practical because, I mean, the bottom line is what's in the patient's best interest. And, but people will argue that even though these are experimental and investigational clinical trials, patients should have the right, provided that they have the decisional capacity and they really understand what's involved in the trial, to participate, to be research subjects. But there are a lot of issues, a lot of conditions, criteria that have to be in place for these trials to be ethically justified and go on. So that's just one aspect. Yeah, I mean, ethics is an important issue. And from my work as a clinical ethicist, if you're a philosopher, you're dealing with theoretical issues all the time. If you work in a clinical setting, you have to be pragmatic. You have to be pragmatic.
If we reduce the person to a brain, as in turn the person into an object, do we value the person as a person or only as an object to our use?
Well, the whole point is not to reduce the person to the brain. Okay. Well, whether it's neurosurgery or oncology, so this drug, this procedure has a 5-year survival rate. Question is, what sort of impact? How's it going to affect your quality of life? Is this something that is acceptable to you? Some people will have different responses to that question. So principles will be behind this type of reasoning, but it is pragmatic in the sense that you've got to, the decision, the agreement between the physician and the patient has to be something that is going to be consistent with medical, bioethical principles, but also in the patient's best interest. And it's always imperfect.
What happens to the brain when the cytokines cross the blood-brain barrier?
Oh, okay. What happens? Okay, so I'm not a psychiatrist, but from what I know, well, they can become psychoactive. So I don't know exactly what effect they have. A psychiatrist could probably answer this on neural circuits, synaptic connections. I don't know, but they can create an adverse environment in the brain. And I mean, just symptomatically seeing how it affects my wife, I mean, there does seem to be something going on there. Now this is, I'm talking about correlation again, okay? And correlation is not causation, so I can't say that the virus triggered cytokines and the cytokines are the explanation of this return of low mood, anxiety, and other symptoms associated with depression is caused by that. But they are psychoactive. Were you shaking your head? Well, okay.
I wasn't shaking my head.
No, okay. No, it looked as though you didn't buy the explanation. Okay, yeah.
I hesitate a bit to ask this, but I live in Utah and I have patients that probably would, and maybe cultures elsewhere. Looking at this, I seem to be hearing primarily the dichotomy of mind-body. How about the triune of mind, body, soul? Other cultures that look at mind and body as included in the soul rather than the soul included in the body. How do you bring that into this discussion with our cultural differences across the planet?
Yeah, there was one slide when I had dualism in parentheses, and I didn't say much about that. Dualism in philosophy and religion is that, well, there are different types. Substance dualism, which goes back to Plato, Descartes, is that the soul and the body are distinct substances. There can be interaction, but the soul can't exist independently of the body. There are certain cultures which believe that the soul takes time to leave the body. Years ago, there was some concern about organ donation, organ procurement because of that belief. So these are cultural beliefs, as you point out, and not the sorts of beliefs that are going to be explained away by saying that, well, neuroscience says that there is no such thing as a soul because all we are material beings. I don't know how the soul, I usually think of the soul as one of these subjective, phenomenological, irreducible, non-reductive aspects of our lives, of our experience, and that do and can play a causal role on not only how we perceive and react to our health or whatever physiological things we have to experience, but may even have an effect on them. There are a lot of theories about the soul, and there's the dualist theory. Aristotle had a theory of the soul where it was not separated from the body. So, but there are, as you point out, there are cultures that think of the soul as a separate entity or a separate substance, and it does play a role in healing. It can play a role in disease pathology as well. And, these are the sorts of things. Some neuroscientists would try to explain that away, but this is an important cultural fact which is there to stay. And if patients have that, I don't think it's the sort of thing that should be discouraged, that they should be discouraged or should think about jettisoning.
It seems to me that we have a lot more knowledge about the developing brain, and we have, as a profession, not taken a very strong stand on protecting young brains who are still growing and developing, especially when it comes to things like underage alcohol and drug consumption. And I think we've all seen those cases where kids get into this stuff and it changes them, sometimes drastically, sometimes immediately. Could you comment on the ethics of us keeping our trap shut during the time when these decisions are being made society-wide?
Yeah. You could, one very controversial issue is fetal alcohol syndrome. This is a big issue. It's in Canada, it has been recently, especially among the Aboriginal population. So there are families where there are children who have fetal alcohol syndrome because of abuse during pregnancy. And the question is, do you take the children away from their mother, away from their parents, and put them in child and family development to foster care, whatever. And there's no easy solution to that. I mean, the assumption is that parents know what's and do what's in the best interest of their children. Sometimes they don't. There are many cases of abuse and neglect. Beyond the womb, if you're talking about young children, then presumably parents still know what's in the best interest of their children. And if there is, and parents and children don't know what's in their best interest, although one has to be careful not to make a universal claim, because some 13-year-olds, even though they're not of the legal age of consent, can be very mature and know what they're doing. Others don't. But in principle, the state has an obligation to intervene to protect them from harm, protect individuals who don't know what is in their best interests and are obviously doing things that harm themselves. Whether taking them away from their families, from their parents, is the way to do that, I don't know. Intervention programs would be the best way to go, I suppose. This is where the social and cultural network comes into play. If there are to do as much as possible to prevent this from occurring, but it's tricky because it involves intervening in the family, in the family and the relationship between parent and child. And when I was working as a clinical ethicist, there were some cases here, and we had to go to the courts to do it. And it's unfortunate when, that is the last resort. It's unfortunate when it comes to that, when one has to go to the courts to get a court order for something like this. I suppose or what some people would take as a less severe issue, and that is vaccinations. There are an increasing number of parents who will refuse to vaccinate or have their children vaccinated because they're concerned about autism and all these other things. Many doctors I know are adamant. They are very upset about that, and they take that to be a form of child abuse or neglect. Yeah, abuse and neglect. Of course, many parents would disagree with that. So what do you do about cases like that? Should all children be vaccinated? My sense is that most of the physicians here would say yes, because it's easy, it's a way of preventing harm, which is not really violating anyone's right. Well, parents might object to that, but that's an issue there, I think, apart from fetal alcohol syndrome, where there's still disagreement about it. Parents will insist that they have the right to do what they want. They know what's in the best interest of their child. And physicians disagree. So there's a collision of the obligation of the parent and the physician here. And I don't know how that's going to be resolved.
I hope this makes sense. I saw a cartoon the other day of a couple walking, and they were noticing all the beautiful trees around them, and they were saying, I know there's a forest around here somewhere. And I think the brain doesn't seek the forest, but it just sees the trees.
Yeah.
And I'm wondering how we can help patients better connect their health to their choices, because sometimes between the brain and the mind there's a little disconnect.
Oh, okay. Well, choices, of course, the ideal is for people to be as informed as have all the information they need to make good choices. So they can have a capacity to make choices enabled by the brain, but the content of those choices, exactly what they do or what the options are, are not going to be determined just by brain structure and function, but it's going to be determined by social cues, the relationships they have with their friends, with their family, and their healthcare providers. So if in a supportive social environment, having all this information will give them the options they need to make those choices. So it's not, there are cases where people will have impaired brain function because of traumatic brain injury or some other condition. And there the social network is crucial because they can, by supporting the individual, enable them to, even though their capacity to make these decisions, these choices is impaired, it can support them to make them in a better way. So this is why family and social support is so important. I mentioned deep brain stimulation. I mean, there's a good example of where caregivers, family members are important. But I don't think I emphasize this enough. I mean, one of the concerns that some neuroscientists have that apart from any sort of brain dysfunction associated with neurological and psychiatric disorders, brain function itself is enough to say that we don't have any control over our thought and behavior. It's the brain doing everything. And I just don't agree with that at all. I mean, to me, it's something that enables, it provides the underpinning for our mind and the choices that we make, provided that it's functioning normally. I don't, whether we have certain choices or the number and the quality of the options we have is going to be really a function more of social factors, social and cultural factors.
Along those lines of cultural and social factors, there are two groups of people of interest to me as far as changing my patients' brains. One is us, where we go in and educate them and teach them something through cognitive behavioral therapy, presumably for their benevolence, but with our own social biases. Yeah. And the other group is panels of psychologists sitting in a marketing advertising campaign causing us to buy cigarettes and alcohol and other things with no intent more than to increase the profit of their hirer. Do we have the right, the benevolent or the malevolent, to change the relational object belonging to another person, the brain?
Okay, well, first, to answer the question of whether you have the right, one would have to know more about how you would affect that change. So what would be involved in making the change?
Certainly, as I'm talking to you, I'm altering the auditory cortex in your head right now.
Okay.
Hopefully, I'm pushing a little bit on the limbic system, and hopefully, I'm pushing a little bit on the frontal lobe.
Okay.
I'm altering your brain as I speak to you.
Okay, so do you have the right to do that? It's interesting because usually in terms of the ethics of the physician-patient relationship, it's usually construed in terms of obligation, not rights. Physicians have the right to exercise their autonomy as physicians in providing the care that they think is best for their patient. So for me to say that you have the right to do this, that's a bit strong. I would say you'd be permitted to do it. Insofar as that's consistent that the intent would be therapeutic and it would be consistent with my best interests, as you know what my best interests are. But it's pretty, usually rights talk, when you're talking about physicians, is limited to the sorts of practices that would compromise the physician's professional integrity. Like the right not to treat a certain patient, maybe, who's abusive, or the right not to, I mean, this is controversial, the right not to treat a patient where the treatment in one's best medical judgment would not benefit the patient at all. So there's the right not to accede to any request that a patient or their family makes. But usually when one talks about, when ethicists talk about interventions that they believe will benefit the patient, it's what they are either obligated or permitted to do. So I would be, I'd be reluctant to use the word right there. Oh, so what's that? Okay. No.